Now let's discuss recent advances in the treatment of fractures. So the AO method of fracture treatment, the AO and its English counterpart, the ASIF, so Association for the Study of Internal Fixation, Association of Study of Internal Fixation. So they advocated the internal fixation of fractures based on principles laid down by them. The basic guiding principle being that by achieving stable fixation of fractures, a limb can be mobilized early. And then you can also avoid the disadvantages of immobilization such as stiffness of joints, muscle wasting, etc., which they termed collectively as fracture disease. So stable fixation, you can achieve it by doing intrafragmentary compression, splinting, or a combination of intrafragmentary compression or splinting. Okay. So intrafragmentary compression, so you achieve compression between different fracture fragments. So mechanically, a fracture fixed with intrafragmentary compression is best fixed. It is rigidly fixed. It is absolutely stable. There is absolute stability. So the fracture fragments are not just merely in contact, but they are compressed, as the name indicates. They are compressed against each other. So compression improves the strength of the fixation. So compression between fragments can be produced at the time of surgery. It is called static compression, and because of limb use, if there is compression, that is called dynamic compression. So what are the surgical methods of producing static compression? So first you have something called the lag or screw fixation, lag screw fixation. So in this, a screw is passed across the fracture site in such a way that when the screw is tightened, the fracture surfaces are compressed against each other. You can see it here. See, the fracture is reduced and held with a clamp. Then what happens is a hole is drilled across the fracture. So the near cortex hole is over drilled. Okay. So as the screw is passed, it slides through the near cortex having been over drilled, and then its threads, they catch the far cortex. Okay. So the head of the screw pushes against the near cortex to the far cortex, producing interfragmentary compression. This technique is suitable for achieving compression across a short oblique or a spiral fracture. Then you have something called compression plating. Okay, so plating is a technique of using a thick metallic strip. Okay, so a plate, as you can see here. So you have a thick metallic plate. See here, you can see over drilled proximal cortex in lag screw fixation. Okay, you engage the screw in the distal cortex. So in plating, what you do is you use a thick metallic strip called a plate, okay, on the surface of the bone. The two fragments of a transverse or a short oblique fracture, they can be compressed against each other using the plate. Okay, so here a short oblique or transverse fracture, they can be compressed by using the plate. Okay. So compression across the fracture can be achieved by a special device called Muller's compression clamp. Okay, here Muller's compression clamp, and or by the use of specially designed compression plates. Okay, so in the latter, the screw holes of a plate are so designed that when the screws are tightened, compression is produced. Okay, so when you tighten the screws, it is compressed. Next, external fixator. So here you can see an external fixator. It can also be used to produce compression between the fragments at the time of its application or by later by gradually tightening the mechanism. Then you have methods of producing dynamic compression. So fractured bone has a tension side. Okay, see here. For example, if you consider the patella, there is a tension side at which the tension is so much and it is always subjected to a distracting force that it tends to open up. Similarly, on the other side, there is compression naturally. So if the distracting tension force is countered by some device which is fixed on the tension side of the fracture, there is compression. So this principle of converting a tension or a distracting force into a compression force is called tension band principle. So you are converting a D into C. So distracting force or tension force into a compression force. That is the tension band principle. So dynamic compression can be achieved by following methods. So you can use a tension band wire. So especially in patella and olecranon fractures, you can use a tension band wire and a tension band plate. Okay. So here this can be applied. This can apply, some pressure on the tension on the surface. So here you can use tension band plates, especially for fractures of long bones like humerus, tibia, etc. Next, splinting. So not all fractures can be rigidly fixed. Okay, so hence stable enough fixation can be achieved by mere splintage as well. So there are several methods of splinting the fracture surgically. They don't provide rigid fixation, but the fixation is good enough to support fracture healing. So first you have intramedullary nail splintage or nailing. So intramedullary nail placement, especially in fractures of shaft of the femur and fractures of the long bones. Okay, so a long hollow rod called a nail is inserted into the medullary cavity of the long bone like this. Next, you have extramedullary splinting or plating. So basically, this can be done for any fracture by applying a plate on the surface of the bone. The plate, it is being used to just splint the fracture without producing any compression is called neutralization plate. Okay, sometimes what happens is you can also see here you can just provide neutralization. Okay, there is no compression. However, if you are providing a plate to act as a buttress, okay, then it is called a buttress plate. Okay. So it is done for fixing tibial condyle fractures. And then you can also do splinting from outside the body. So pins are inserted through the skin into the bone and the same are held outside with clamps and rods. Okay, so external fixators. They're used to hold the fragments of an open fracture, for example. Okay, so you have intramedullary nailing, neutralization plating, buttress plating, especially for tibial condyle fractures, and splinting by external fixators. Then you can also have a combination of compression and splinting as well. So this combination of principles is required in achieving stable fixation in most fractures. For example, a spiral fracture of the shaft of the femur can be stabilized using intrafragmentary screws across the fracture and a neutralization plate to add for fixation. So basically, before the 1950s, non-operative treatment was an important thing. So basically you just depended on the callus formation for healing of the fracture. So this, however, led to stiffness of joints and wasting of muscles, so-called fracture disease. So in the late 50s, the AO group, what it did was it proposed anatomical reduction of the fracture. So the fragments were rigidly fixed using AO principles. Okay, so the aim was to achieve bone-to-bone healing without any callus formation. So it is primary bone healing. So it became necessary to expose the fracture, open it up, and while anatomically fixing it, you were damaging its blood supply essentially. So even though it was mechanically superior, it does not respect the biological environment of the fracture because you're compromising on the blood supply. So even if it is well fixed, the fracture will often fail to unite. So the current concepts, they changed. The current concept, it is stable fixation, not rigid fixation. So see, it could be rigid fixation in certain situations like intra-articular fractures, for example, where exact anatomical reduction in rigid fixation is a must for getting the fracture to heal well and also to mobilize it early. On the other hand, for diaphyseal fractures, anatomical reduction, it is not a must. Okay, just functional reduction. So achieving length and a more biological preservation and a less than rigid, a relatively stable fixation is good enough. Okay, for example, in the past, if there was a comminuted fracture of the femur, you would fix each and every single broken part with screws and plates. It was like solving a jigsaw puzzle, but it damaged a lot of the blood supply, leading to delayed union and non-union. But in the current perspective, the same fracture is stabilized by using a bridging plate. Okay, so you use a bridging plate or a nail where the length of the bone and its alignment is restored without exposing the comminuted segment of the bone. There is relative stability. Okay, so this causes stable fixation. In order to preserve the blood supply of the fracture, emphasis has shifted again from direct reduction, from where the fragments are exposed and directly reduced, to indirect reduction, where the reduction is achieved by manipulating the limb without touching the fracture. So you can do closed reduction as well. So in general, intramedullary nailing has been considered as a mechanically superior device compared to plating. So a nail acts as a load sharing device. Okay, the load is shared by the bone and the nail as well. The only disadvantage is that a nail does not provide rotational stability to the fracture. So what happens, what was done was, see, the conventional nail, holes were made at the ends of the conventional nail and interlock nailing was done. So this provides rotational stability as well. Okay, it is now the state-of-the-art treatment for fixation of long bone diaphyseal fractures. Okay. And then again, there is a change in the design of the conventional plates as well. The new plates are designed such that they are in contact with the bone at minimum surface. So low contact DCPs, so dynamic compression plates. This allows for better vascularization of the structure under the plate because the contact is less. Next, the latest development in plating technique is LCP, so locking compression plate. So this has a mechanism where the screw head is locked into the plate. So the one popular one is using a combination screw hole. So it has two halves. One half is like a conventional DCP hole, unthreaded, and the other half is threaded. Okay, and even the screw is threaded. So here you can see a threaded part and a conventional part. So this provides a rigid plate screw construct, and this has been found to be mechanically superior to a conventional plate. The LCP is a versatile plate. It can be used in different modes. So compression mode, neutralization mode, buttress plating, bridging plating, and as an internal fixator as well. And right now you also have anatomically pre-contoured plates specific for specific regions of the body. And you also have biodegradable implants. And next, there is something called functional bracing. Okay, in this bracing principle, you have to apply an external contraption called a brace to a fractured limb. So it is done if the reduction of the fracture is satisfactory and the swelling has reduced usually 2 to 3 weeks after the injury. So basically what happens is, it supports the soft tissues in a tight compartment. So there is axial pressure on the limb. It tends to shorten the bone segment, and it produces a bulging effect on the soft tissues. Since it is all a confined space, this develops a pressure within the brace, hydraulic pressure, which helps in maintaining the fracture alignment. Bracing, see, it will not reduce the time taken by the fracture to heal, but it markedly reduces the stiffness and wasting of muscles. So the fracture disease, it reduces that. Okay, it's also used for a fracture fixed internally where internal fixation is inadequate. Okay. And then you have Elizarov's technique. So he revolutionized the application of external fixation in the management of difficult non-unions and limb lengthening. So the basic premise of Elizarov's technique is that osteogenesis requires a dynamic state. That means the site of osteogenesis, okay, the site of a fracture requires either controlled distraction or controlled compression. This dynamic force, when properly applied, causes the dormant mesenchymal cells at the non-union site to differentiate into functioning osteoblasts. This results in bone synthesis and fracture healing. So the concept that compression enhances the bone healing was known even prior to Elizarov, but distraction osteogenesis, he was the one who stressed on it. So according to this theory, any living tissue when subjected to constant stretch under biological conditions can grow to any extent. So the biological conditions are provided by aligning the fracture with minimal damage to its vascularity. So biologically are respecting the fracture. And then performing an osteotomy of the bone, especially in limb lengthening surgeries, without damaging the periosteal and endosteal blood supply. Such an osteotomy was termed corticotomy by Elizarov. So the whole segment of the limb is stabilized by a specially designed fixation system called a ring fixator. Okay, this protects the growing tissues from bending or shearing forces but permits loading in the long axis of the limb. So distraction or compression can then be applied at the fracture or corticotomy site by twisting nuts on the fixation system. Okay, so distraction is carried out at the rate of 1 millimeter per day, 1 mm per day, and it is done in 4 sittings. So 1/4 mm 4 times a day. So ring fixator application, you pass stainless steel thin wires through the bone. Outside the limb, the wires are attached to rings with the help of bolts. Okay, before fixing the wire to the ring, you put the wire under tension to make it stiff and then impart stability to the fixator. The rings are interconnected with the help of threaded rods. Okay, threaded rods with nuts on either ends. Okay, and then it is by twisting these nuts, okay, that the rings can be moved up or down and the fracture distracted or compressed. So the use of external fixators has undergone ultimate sophistication. Again, now computers are also being programmed, are being used to program the application and monitor the distraction and compression. Elizarov's technique is useful in the management of limb lengthening. So basically, when there is a shortening associated with limb deformity, you can do massive limb lengthening by using Elizarov's technique. Up to 18 inches, massive limb lengthening has been performed. And non-union, because you are stimulating the osteoblasts in a biologically, a stable environment. So again, non-union sites also, they heal. Next, deformities can also be corrected, be it congenital or acquired. Osteomyelitis can be treated, as this technique offers the possibility of liberal excision of the necrotic bone, and arthrodesis can be performed by crushing the articular surfaces against each other and then stimulating union between the bones. So advantages, there is immediate load bearing, healthy viable bone in place of a devascularized bone, so you can remove the necrotic part as well. And then correction of more than one problem by one stage operation. So you're correcting non-union, you're correcting limb lengthening, all these things. So disadvantages, see, it is inconvenient and it hampers normal activity. It the duration is very long. There could be some infection. It can cause nerve palsy, okay, joint stiffness as well.